A very good evening to all of you. This is Prashant from NABH Secretariat. Now we are here for our next webinar, which is on FMS and ROM checkpoints, and will be presented by Dr. Prashant Kelkar. After the webinar, we will have a question answer session, and once the question answer session is over, we will have a small discussion about whatever queries you have. So without wasting any time, I hand it over to Dr. Prashant Kelkar to start the webinar. Sir, can you hear me?
Yeah, I can hear you, Mr. Prashant.
Yeah, sir, you can start the webinar, please.
Okay, thank you. Thank you, Mr. Prashant. And good evening to all of you, and welcome to this next session of the webinar series. Today I'll be talking about the ROM chapter and the FMS chapter and the checkpoints related to these, following which we can then have the question and answer session as Mr. Prashant pointed out. So looking first into the ROM chapter, we see that there are very minimal changes that have been made to the ROM chapter, and only one new element has been added, whereas the number of standards remains the same. So we have still 6 standards in the ROM chapter and 39 objective elements instead of the 38 objective elements. Looking at the first element, the ROM 1A, it says that those responsible for governance lay down the organization's vision, mission, and values. The modified interpretation removes the ambiguity and requires that those responsible for governance release an authorized document which mentions the vision, mission, and values. ROM 1F, the next element, which states that those responsible for governance support safety initiatives and quality improvement plans. The modified interpretation now ensures that the safety and quality committee reports reach the board of directors or other similar levels of governance, so that they can then allocate the funds and resources for necessary corrective and preventive action which is required for the same. ROM 1H, the element remains the same. Those responsible for governance address the organization's social responsibility, but the interpretation has been modified to add support to the national health programs within the scope of services and statutory requirements. Now, this is another way of demonstrating the organization's social responsibility and commitment. Various programs such as the National Vector-Borne Diseases Control Program, the National Program for Control of Blindness, and the National AIDS Control Program, for example. These are the different programs or several other programs that the organization can support. And I think all of us will recollect the recent declaration by the government related to the National Dialysis Program, which will be soon launched in the country. So this particular element and the interpretation talks about supporting the national health programs. So the assessment checkpoints for these 3 elements, the ROM 1A, F, and H, have taken them together, in which we can have interviews with the top management to see the release of the vision, mission, and values document, to check whether the review of safety and quality committees is being done, and this should be followed by allocation of resources and funds accordingly, and to discuss with them the support to national health programs and evidences related to those. Going ahead to the ROM 2, where the slight change in the wording has been done, and it now states that the organization is responsible for and complies with the laid down and applicable legislations, regulations, and notifications. So the notifications part has been added now. And in the ROM 2A element, the management is conversant with applicable laws and regulations and undertakes the responsibility to adhere to the same. Now this, in other words, this modified objective element and interpretation means that the hospital abides by the laws and regulations and gives an undertaking to this effect. We have already been taking indemnity letters from the organization stating that they are responsible and they adhere to the different laws and regulations, and this particular element also emphasizes or stresses on this aspect. So it reduces the ambiguity on the responsibility of who is to adhere to the regulatory and statutory requirements. Going ahead to the ROM 2B, which is a new objective element which has been added to raise the bar. It states that the management ensures that the policies, procedures pertaining to patient care are in compliance with the prevailing laws, regulations, and notifications. Now, in other words, this is a new OE which is drawn and is rephrased from the old OEs, of course. And we all know that the different laws have their own compliance requirements, and this particular objective element looks at implementation requirements to these regulations and notifications. They may be in the form of maintaining the records of drugs related to the Narcotics Act. They may be related to the maintaining confidentiality and submitting monthly reports related to the MTP Act, and several other acts have their own regulatory requirements. So this particular element looks at implementation of these requirements. Also, this element, if you notice, it talks about notifications. So examples of notifications which have been given here: the guidelines and protocols for medical legal care of victims, survivors of sexual violence, various other notifications which are released from time to time. It may be the notification related to the IVF clinics, the notification related to the by the FDA for banning certain drugs, or even the new notification which has come related to including the B scan under the PCPNDT Act. So these are some of the regulations and notifications which have to be complied by the organization. We now come to the seventh point, that is the ROM2C element, where it states that the management has a mechanism which ensures implementation of these requirements, and which, in other words, this modified objective element and notification requires that there be a process in the organization which ensures implementation of the legal requirements, which includes having a designated management functionary. Now, a person who is dedicated for doing this work and who has identified certain other people in the organization who can work with him towards implementation of the respective laws and regulations. ROM2E, there is a mechanism to regularly update licenses, registrations, and certifications. Here the modified interpretation now brings more clarity in asking for timely renewals of applications, so that some of the acts require renewals to be applied before expiry date. Some of them are okay with expiry date for applications made a few months after the expiry date. So depending on what is the requirement of the statutory regulation, the timely renewals have to be made. So this is what this particular objective element talks about. In a nutshell, when we look at the ROM2, the ROM2A is looking at having required licenses, ROM2B having the policies and procedures in compliance to the laws and regulations, ROM2C a mechanism to ensure the compliance to requirements, ROM2D regular updations with respect to amendments in the laws, and ROM2E regular renewals of the licenses made in time. Now, when we are doing an assessment, the assessment checkpoints for the ROM2 standard would be an interview with the top management and the designated functionary who is designated for this particular activity. Looking at the undertaking letter which has been given by the management, a review of the licenses to see whether they are valid or they have expired, and the compliance status of the HCO to the implementation requirements. As I mentioned earlier, when we are visiting different areas, we would look at the different compliance requirements. Also, we would look at the timely renewals made and applications made for renewals and the tracker sheet to track the same. Going ahead to the next objective element, the ROM3D, where the phrase has been added to indicate that the department leader or a designated person who has been designated by him or her is responsible for achievement of the departmental objectives. ROM4F, the organization accurately bills for its services based upon a standard billing tariff. The interpretation explains this, that it actually means that the organization does not charge differentially from different patients in the same bed category for the same surgery or procedure. ROM5C, the modified interpretation, the interpretation has been modified. This is the element on strategic and operational plans, and the modified interpretation brings clarity on how the inputs should come for the strategic and operational plans. And some of the inputs that could be considered while making these plans are from the findings of the risk management plan, the patient safety goals, and the result of facility rounds. These are some of the things that would guide the preparation of strategic and operational plans, which should be done at least on an annual basis. ROM5G is the element on functioning of committees, which is reviewed by the top management. Now, the interpretation has again been modified to raise the bar, and it requires that the review of committees is now supposed to include monitoring of the corrective and preventive action on the points that have been suggested by the committee by the way of risk mitigation. So it is not that you can stop at committees suggesting some things. This used to happen, that committees used to suggest some recommendations, used to suggest some actions, and then it used to remain at that point. So we now require that the top management review whether corrective and preventive action has been taken based on the suggestions made by the committee. ROM5I, this is the organization documents the service standards. This element, again the interpretation has been modified to bring better clarity, and it states that the service standards should be based on the organization's mission, vision, and values. For instance, if the mission statement has a wording saying that it doesn't discriminate, the organization does not discriminate based on the caste, creed, and language, then the service standards which are developed should reflect this particular ideology. ROM 5K, the organization monitors the quality of outsourced services, and the modification in the interpretation now brings out the prescribed frequency for monitoring of the quality of outsourced services, which has been mentioned that it should not be less than once a year. Although it depends on the criticality of the service, so that we have already seen in the HIC chapter where the requirement for visit to the outsourced biomedical waste vendor, for example, should be done once in 6 months. So although the minimum frequency has been mentioned as once in a year, this can be required to be done more frequently depending on the criticality of the situation or the service. The additional checkpoints for ROM 5 standard, I'm not going to talk about the checkpoints for the issues which were there mentioned in the earlier edition, just the additional checkpoints for the points which have been added in the 4th edition. And it's mentioned that we should check whether the strategic and operational plans reflect risk analysis results, patient safety goals, and facility round reports. Check whether the top management reviews the corrective and preventive action following the committee recommendation. Check the service standards to see whether they correlate with the organization's mission, vision, and values, and review the monitoring of outsourced agencies, and check the frequency of this monitoring, which should at least be once a year. Going ahead to the ROM 6, where which talks about the internal and external reporting of system and process failures. Here certain examples have been added in the interpretation, such as in case of radiation source, external agency reporting is to the ARB, and what to be done in case of fire incidents. So such examples bring out the interpretation of internal and external reporting of system and process failures. Now there is one deletion in the ROM chapter, which is that the organization plans and budgets for its activities, and the interpretation used to mention that it is preferable that every department has a budget. Now this particular departmental budget requirement has been removed and deleted to remove the ambiguity, so it is not required anymore for every department to have its own individual budget. Looking at the ROM chapter overall, if you see that there is a lot of clarity now brought in what is required for the adherence to the legal requirements, also that the reports of the quality and safety committee are shared by the management, and then they take further action and they allocate funds and resources for that. The awareness and support to the national health programs has a new thing which has been added, and that the strategic and operational plans are now based on several inputs such as risk management, patient safety goals, facility rounds, etc. So a lot of improvement has been made on the ROM chapter to make it more comprehensive, though not much changes have been made as compared to the 3rd edition. With that, we come to the end of the chapter on ROM, and now we'll go ahead to the chapter on facility management and safety. In which we can see that several changes have been made, and basically okay. So now we talk about the facility management safety chapter, where some changes have taken place. If you look at the number of standards, one of the standards has come down, and from 8 standards is now down to 7, because one of the standards on community emergencies and epidemics and other disasters has now been shifted, and it has gone to the COP chapter on COP4, as all of us have seen earlier. The number of objective elements has increased from 54 to 56. In fact, if you remove the number of elements which were there in this chapter, in this standard on community emergencies, you will see that a large number of new objective elements have been added to this particular chapter. And in general, as you go through the standard, you will notice that in terms of safety aspects of the hospital, several aspects which were hitherto uncovered in the previous editions have now been addressed in the 4th edition. So sort of closing the gaps has now been done. The intent of the chapter focuses on proactive risk mitigations, and that another last line added, the organization works towards measures on being energy efficient. So more of focus laid on these two aspects in the new edition. FMS 1A, the safety committee coordinates development, implementation, and monitoring of the safety plan and policies. Here again the interpretation has been modified to bring more clarity, in stating that there is more stress on making the facility and environment safe, and on having the safety committee members who will now function as patient safety and or facility safety officers, and the hazard identification and risk analysis, the HIRA, are done in both clinical and non-clinical areas. So the analysis to be done not only in the clinical areas but also very important in the non-clinical areas. So these are the three things that have been now added in the interpretation of the functions of the safety committee to bring more clarity in the same. Looking at the FMS 1B, patient safety devices and infrastructure are installed across the organization and are inspected periodically. So here again the interpretation, one sentence has been added to raise the bar, because here we are now looking at making provisions available for physically challenged and vulnerable patients. This is also a statutory requirement now, especially having special toilets for the physically challenged individuals. Some of the other facilities which may be provided to the physically challenged group of patients is having a reception counter which is suitably heighted for these patients, having ramps to allow easy access for this group of patients, wide doorways where the wheelchairs can be moved around, spaces in cafeterias and waiting lounges to park these wheelchairs, and if possible attendants to supervise the safety of these patients. And more information on the requirements of the disabled patients can be found on this website which has been listed here. Now let me mention here that these are only some of the suggested measures. We as assessors, we should not look at the provision of all these measures which have been listed down. It is enough if we look at the provision of dedicated toilets for the handicapped patients, physically handicapped patients, because that is something which is a statutory requirement. In addition, we should also look at the intent of the hospital to provide a comfortable and safe atmosphere to this particular group of patients. Assessment checkpoints, again, besides looking at the different safety devices which we used to look into, we would also again look, as I said, for a special toilet for physically challenged patients with a wide door, and where entry of the wheelchairs and other facilities can be made very easily. FMS 1D is a new objective element which has been added to address the identification and disposal of materials which are not in use in the organization. Very often when we go around hospitals, we find a lot of material, lot of unwanted material, items which are not in use, equipment which is not in use, general waste, scrap materials lying here and there in the hospital, and which definitely causes a trip, slip or a fire hazard, and also acts as a source of infection. So this particular element has been added so as to address all these things, where the organization is now required that the organization identifies such material and condemns and disposes this material in a very systematic manner. FMS 1E facility inspection rounds are conducted to ensure safety at least twice a year in patient care areas and at least once a year in non-patient care areas. Here again the interpretation has been modified to bring more clarity in including potential security risk areas and restricted areas which should be identified, and a mechanism to work out to monitor and secure these identified areas. We have not specified which methodology is to be worked out, what mechanism is to be worked out, whether it be in terms of posting more security personnel, in terms of having better lighting, or having more CCTV cameras placed in these areas. That's left to the organization to decide. But the organization should definitely find out the potential security risk areas and areas which are high risk and are restricted, so that a methodology is found out for the same. Now, there are some pictures I found useful maybe for some of you, which show some of the areas which may be potential security risk areas, like a breach in the compound wall, or gates which are unmanned, or unused areas or corridors. Certain restricted areas such as the liquid oxygen tank, the diesel storage area, and maybe also the data server room, and several such areas which require special security arrangements. So the organization needs to identify such areas and have a mechanism to ensure safety and security in these areas. FMS 1F, the inspection reports are documented and corrective and preventive measures are undertaken. This particular interpretation of the element has been modified to indicate that the reports have to be maintained and reviewed periodically, and reports of the corrective and preventive actions which are taken based on the inspection findings have to be maintained for at least one accreditation cycle. Now, this is necessary because this will ensure that the facility reports, the inspection reports which are there, are followed up by a particular closure of the deficiencies and corrective and preventive action based on the same. This to bring more clarity. FMS 1G, there is a safety education program for staff. So the interpretation has been modified to mention that the safety education program should be included as a part of the employee induction as well as a refresher training program. This should include the various components such as training on fire safety, occupational safety, radiation safety, lab safety, and other areas as per the scope of services of the organization. Assessment checkpoints for the FMS 1, D, E, F, and G, I have taken them together because when you are on facility inspection rounds, when you are reviewing the facility inspection rounds, check whether the organization itself has identified unwanted items lying around here and there, identification of security risk areas which I mentioned earlier, and a review and corrective and preventive action taken based on the deficiencies found during the facility inspection rounds, and these be retained for one accreditation cycle. When you as assessors or we as assessors are on facility rounds, at the time of assessment we should look for such unwanted non-functioning items which have not been disposed of, should look for security risk areas which have not been identified and which need to be identified. Also check for the disposal of items as per the condemnation policy of the organization. Look into the training records and see whether safety training has been added in the induction training as well as the refresher safety training, and conduct staff interviews using what if situations to know what they would do in certain safety situations. FMS 2, the organization, environment and facilities operate in a planned manner to ensure safety of patients, their families, staff and visitors, and promotes environmental friendly measures. Now this interpretation has now raised the bar for this FMS 2 standard, and the FMS 2E, this element talks about having operational planning, describes access to different areas in the hospital by staff, patients, visitors and vendors. So this new objective element now addresses the issue of access control to different areas, and the interpretation states that there is a process and means to identify staff, visitors and vendors, and access is controlled in different areas as per the organization's policy. It is again left to the organization to decide what are the different ways in which access control can be taken care of. It might be in the form of providing category specific uniforms to different categories of staff, providing the use of identity cards, using restricted area signboards, and having dedicated visiting time for visitors. So these are some of the different means that can be used to restrict access control. The access assessment checkpoints for FMS 2E is looking at the access policy and seeing the compliance to this policy as assessed when you are doing different rounds and visits to areas. Check how people are moving around, check how patients are moving, staff are moving around, visitors are allowed access or denied access. Look at the display of visitor timings which is mentioned and pasted as signboards. Look at having adequate security staff to check access control, and sometimes you might even want to do an unaccompanied round in an area to check whether you are being denied entry to a particular area because you are not allowed access to that particular place. Coming to the next objective element, FMS 2F, which is about potable water and electricity. Now here the interpretation prescribes that the potable water quality is monitored quarterly or more frequently and documented. So the frequency of monitoring of potable water quality is now mentioned here, which should be done at least once in a quarter. But sometimes it may be required to do more frequently. For example, you have a situation where say in the monsoon seasons, or you have an outbreak in the community where you might want to do the potable water quality checking more frequently than once in a quarter. And the respective IS standard 10500 can be referred to for different aspects related to checking water quality. Going ahead to FMS 2G, the element which talks about alternate sources for electricity and water provided as a backup. Now the interpretation has been modified to give a better clarity to mention that the healthcare organization should identify the risks to various critical areas and activities due to electricity and water failure and find ways to mitigate the same. Also that the healthcare organization ensures that in the event of electric failure, the capacity and longevity of the UPS and the DG set support the services. So it should not happen that at any point the UPS is not able to support a long-standing power failure, and for this reason, for example, the SCO can provide a long-life power backup for the ICUs and the OTs. For this particular objective element, assessment checkpoints could be review the risk management plan, whether it includes the risk of electric water supply failure to critical areas, Review the capacity and longevity of the DG sets and UPS with respect to the power disruption pattern. So compare the timings of the power disruption to the time for which the DG set and UPS can support power, especially in the critical areas, and also study the records of regular testing of DG set and UPS. FMS 2I about having designated individuals responsible for maintenance of the facilities. Now here we require that they have appropriate equipment, so the interpretation also states that necessary infrastructure and tools are available, like the ladder, voltmeter, spanner, and various safety norms are followed by the maintenance staff. They know how to use the staff and they have the proper safety equipment to keep themselves safe. FMS 2K, there is a maintenance plan for facility and furniture. Now this is a new objective element again addressed towards maintenance of the facility and furniture. We often hear of cases where the ceiling has fallen down, or the trolley wheels are not working, or somewhere the broken chairs have injured patients or they've injured staff. There's nothing as of now to address these issues. Even when we used to go for assessments, we used to find such things and we used to find it difficult where to fit in this particular deficiency, and now we have an element which addresses this, and it means that there is a maintenance plan which includes civil work. It also includes maintenance of loose furniture and fixed furniture, and this plan should adhere to the manufacturer's recommendations and also look at infection control requirements. And the plan also includes regular inspections, timely repair of civil structures like walls, furniture, etc. Assessment checkpoints for FMS 2IK: look at availability of infrastructure and tools for maintenance staff, check their inventories, use of safety equipment appropriately by the maintenance staff, look at the maintenance plan for civil work and furniture, and look at the service reports and the repair reports for civil work and furniture. FMS 2M, the organization takes initiatives towards energy efficient and environmental friendly measures. This is again a new objective element, and I would say that this is one of the most significant and relevant additions to this 4th edition NABH standards, because it drives the HCO towards developing green hospitals. This is the first time that environment friendly measures and energy efficient measures are addressed in the NABH standards, and it includes concepts of reduce, recycle and reuse in promoting the basic concepts of green hospital, such as energy efficient lighting, rainwater harvesting, use of renewable sources and recycling, etc. We can find more information on the energy efficient and environmental friendly measures in the book of annexures to the standards. So some of the assessment checkpoints for the FMS 2M would be looking at whether there is optimum water usage and usage of measures such as rainwater harvesting, optimum energy usage, energy efficient lighting, renewable energy sources, waste management measures and recycling of material, usage of environmental friendly material, look at the indoor and outdoor environment, look at the lighting, ventilation and landscaping there, and look at whether the staff has been educated on energy efficient and environment friendly measures. Here I'd like to stress again that at this stage, when we have just added these new elements, we need to be a little flexible and not be too rigid on insisting that the HCO follows all these measures towards energy efficient and energy and environment friendly measures, because it is important that we need to see whether the intent of the organization is that they have embarked on this journey and they have implemented at least some measures towards conserving the environment, towards conserving energy. FMS 3C, the equipment are inventoried and proper logs are maintained as required, and this interpretation has been modified to mention that a unique identification is provided to each equipment where applicable, and this where applicable, the relevant quality conformance certificates also should be retained. Now this is regarding the engineering equipment. Again, in FMS 3D, the qualified and trained personnel operate, inspect, test and maintain equipment and utility systems. The interpretation has been modified to give it more clarity and to mention the requirement of having inventories to be maintained with the general engineering team, such as bulbs, paints, etc. And during assessment, the inventories of the engineering team can be verified. FMS 3E, a new objective element has been added to address the requirement of inspection and calibration of utility equipment for their proper functioning. Equipment such as pressure gauges of steam sterilizers, temperature gauges of medication refrigerators, etc. So whether the organization calibrates this equipment in-house or outsources this mechanism, the maintenance of traceability to national and international standards should be maintained. FMS 3F, this element which looks at the documented operational and maintenance plan for engineering equipment, utility equipment, the interpretation has been modified to bring more clarity on the meaning of the operational plan and the maintenance plan, where the operational plan can be drawn from the original equipment manual, the OEM. In case this OEM is not available, then the organization shall develop its own operational plan, whereas the maintenance plan should consider the manufacturer's recommendations, the risk level, and the past maintenance history. When we are looking at the assessment checkpoints for the FMS 3 CDEF, which is looking at general engineering, we need to look at the review. We need to review the inventory logs and check whether the equipments have unique identifiers. When we are going around during visits, during facility rounds, we need to check whether each equipment is uniquely identified, whether the engineering team has all the required inventories relevant to their maintenance activities. We need to review the operational and maintenance plan to see whether it complies with the requirement of the standard. We need to review the records of calibration, whether they have the required traceability certificates, and we need to go into the maintenance trackers of equipment to check for the preventive and breakdown maintenance. When we are on facility rounds, we can also check the functional status of such equipment and correlate it with the maintenance trackers. FMS 3G, the maintenance plan for water management. Now the interpretation has been modified to bring better clarity, to include regular checking of the pH, of the total dissolved solids, the hardness, etc., which all should be included in the water management plan. FMS 3J, again another new objective element which has been addressed to look into the maintenance plan for information technology and communications network. The interpretation of this particular element is that this particular plan should include data server units, telephone exchange units, computers, telephone lines, nurse call systems. In fact, all the hardware and some aspects of the software which are included in providing communication networks to the hospital. It may be in the terms of maintenance of the network switches, in terms of software upgrades, in terms of system patches. All these things should be included in the maintenance plan, and these should adhere to the manufacturer's recommendations. There should be regular inspections and timely repair of the telephone units, printer units, other hardware equipment. Assessment checkpoints for FMS 3J, look into the documented maintenance plan, the preventive as well as breakdown maintenance plan for the IT and communication network, like the mobile phones and the PA systems, other hardware and peripherals. Also look at the records of maintenance, whether the complaints of IT and communication networks have been handled in time or not, whether the preventive maintenance has actually been done in time or not. These are some of the things that we need to review during assessment for the IT and communication network maintenance. FMS 4C, the equipment are inventoried and proper logs are maintained as required. Now we are coming to the medical equipment, where again the interpretation has been modified to state that a unique identifier is provided for each medical equipment. And again in the FMS 4D, we require that the qualified and trained personnel operate and maintain the medical equipment. The interpretation has been modified to bring better clarity, to state that the operators of the medical equipment should be trained to use medical equipment. It may be nurses who are using, the technicians who are using various equipment. All the personnel who operate and maintain the medical equipment, they should be adequately trained on the maintenance and use of the medical equipment. FMS 4F, this is regarding the operational and maintenance plan for medical equipment. Now, just as we saw that there is a modified interpretation to bring more clarity into the operational plan and the maintenance plan for engineering equipment, even in the medical equipment, the interpretation has been added to detail the requirements of the operational plan and the maintenance plan, where again the operational plan can be drawn from the original equipment manual, and in case that is not available, it can be, the organization is required to develop its own operational manual, And here we require that the operational plan includes evaluation of safe usage of equipment, a sort of audit or monitoring whether equipment is being used safely or not, and that the maintenance plan includes periodical checking, inspections, timely preventive maintenance, and any breakdown maintenance, also responses which should be timely. And especially we have included the terminology of including at night and weekends, because this is the time at which sometimes the responses to breakdown issues may be slow or may not be timely. And so it is necessary that even at odd times in the night or during weekends, immediate responses to any breakdown complaints of medical equipment are addressed urgently. Assessment checkpoints for the medical equipment maintenance, where we would look at the review of equipment logs, whether the log shows unique identifiers. During visits also we can check whether each medical equipment has been identified uniquely and given a unique identifier code. Staff training on the use of equipment, staff awareness on the safe and effective use also can be checked by staff interviews. And we should be able to notice the availability of operational manuals, operational plans on site, and should review the operational maintenance plans. Also look at whether the organization is reviewing the evaluation of safe usage, which I said, monitoring how the usage is being made safely of the medical equipment. Preventive and breakdown maintenance records should also be looked into, and look into the service reports, look into the breakdown reports, which you should focus when you're on assessments. Look at complaints which have been raised at night times, look at complaints which have been raised on weekends, and check whether responses have been adequate, whether the complaint has been addressed and ratified as early as possible. FMS 4H, the procedure addresses medical equipment recalls. This is again a new objective element which has been added to address this issue, which sometimes it comes up that recalls are made by the manufacturer itself or by some regulatory authorities based on some technical issues. There may be some safety issues for the reason for which such medical equipment is recalled. Now, whenever the hospital becomes aware of such a recall, it is expected that the organization immediately stops the use of such medical equipment and does not use it until the time this issue is resolved. So this is a new objective element which is addressing the issue of medical equipment recalls. FMS 4I, another new objective element which is now added for the medical equipment. In the third edition, it was added in the chapter on in the standard on general engineering equipment. It is now also added to the medical equipment, because here also the response times monitoring is very important, and the response time should be monitored from reporting to inspection to the implementation of corrective action. So we need to have a register, a complaint attendance register, which is maintained either physically or electronically, which indicates the time of complaint, the time of allotment of the job, the time of attendance of the job, and the time at which the job is completed. And always the completion of job should be ratified by the user department. This is another deficiency which we find often, that it is the biomedical equipment, biomedical engineering department itself which says that we have now ratified the complaint. The complaint should always be ratified, completion of the complaint should always be ratified by the user departments till their satisfaction. Assessment checkpoints for FMS 4H and I related to FMS 4H related to the medical equipment recall, and FMS 4I related to the response times monitoring. So for the medical equipment recalls, we need to look at having a procedure for equipment recalls. We need to look into whether there are any backup plans in case the recall is there, in case a particular equipment has to be recalled for as per the regulatory authorities notification, whether any backup plan has been made for any backup equipment, and what is the compliance to the procedure, laid down procedure in case any recall occurs. If any recall has occurred, we need to check what procedure has been followed. Regarding the response times monitoring, we need to look at the complaints attendance register, whether the different times have been noted, the time of complaint registering, the time of attending the call, and the time of ultimate resolution, and to check whether these response times are being monitored for further action. FMS 5B, medical gases are handled, stored, distributed, and used in a safe manner. So this again has been modified, the interpretation has been modified to specify that the compressed air purity Earlier we used to say it has to be measured once a year, but the location was not specified. Now the 4th edition specifies that the location of checking compressed air purity should be done from one terminal at least from the OT and the ICU. FMS 5C, the procedure for medical gases, addresses safety issues at all levels. This interpretation has been modified to specify that the requirement of an auto changeover from one source to the alternate source. So from the primary bank to the secondary bank of gas cylinders, an auto changeover is expected. FMS 6B, the organization has a documented safe exit plan in case of fire and non-fire emergencies. In this case, the interpretation has been modified to raise the bar and to add that the safe exit plan should also include non-fire emergencies in its documentation. FMS 6D, mock drills are held at least twice a year. The interpretation has been modified to say that the mock drills are conducted at least twice a year for fire and important non-fire emergencies. So we need to first identify which are the important non-fire emergencies that can occur in that particular location, and then conduct mock drills related to fire as well as non-fire emergencies, and this should be done at least twice a year. FMS 6E, there is a maintenance plan for fire-related equipment and infrastructure. The interpretation has been modified to bring more clarity on the various components of the fire-related equipment maintenance, such as inspection, testing, preventive and breakdown maintenance. FMS 7D, the plan for managing spills for hazardous materials. Now the interpretation has again been modified to remove ambiguity and to add and to suggest that the organization should have a hazmat kit as a part of its PPE for spill management. One of the deletions that has occurred, as I mentioned earlier, has been that the chapter on the standard on community emergencies, epidemics and other disasters has now been shifted from the chapter on FMS to the chapter on COP. It now takes the place of the COP 4. It has gone to the COP 4 chapter now. Overall impacts of improvement, if you see, several gaps, as I mentioned, have now been plugged in. There is nothing to look into aspects such as identification and disposal of materials not in use. There is nothing to talk about maintenance plan for facility and furniture, of maintenance plan for IT equipment, for recall of medical equipments, for looking into identification of specifically the security risk areas. So all these areas, all these aspects of safety which were up to now not covered by the previous editions have now been covered in the 4th edition. And at the same time, the important issue of energy efficient measures and environment protection, which is now globally being recognized as one of the most important issues, is now addressed through the 4th edition standards. So this was the overall impact of the improvements of the FMS chapter in the 4th edition. With that, I come to the end of my talk on ROM and FMS, and I'll request Mr. Prashant to start the Q&A session. Thank you so much.
Thank you very much, sir, for your enlightening session. Now we will start taking the questions from the assessors. So the first question I am taking from Dr. Rajiv Kumar. Dr. Rajiv, can you hear me? Dr. Rajiv?
Oh, yes.
Yeah, sir, you can ask your question directly to Dr. Prashant. He can hear you.
Okay. So, Dr. Prashant, hi, good evening.
Hi, good evening. How are you?
Yeah, I'm fine. So, actually, I'm facing challenges while doing the audit assessment on this ROM interview. So, as per the standard, there are 3 things. As per the standard, there are 3 things. One is governance in ROM 1. Another is management in ROM 2 and ROM 6. Leaders are in ROM 3 and ROM 4 and ROM 5. So, is there any definition defined in the standard for the COs? What is governance? What is management? What is top management? And what are the leaders? Who are the leaders in the organization? So we have also for the departmental leaders, and you have NABH has in the 4th edition has added or delegated by some others in the designated person in ROM 3D. The objective element is departmental leaders, and in the interpretation that is added a / designated person.
Yeah, that's
So
right.
there is an ambiguity in all these things. So there should be some clarity on this. Can you give your opinion and your experiences?
Yeah, sure. Now, there are three levels of governance as we can look at it. The departmental leaders who look at what the heads of various departments, the head of the organization who's looking to the day-to-day activities of the organization, and then we have the board of directors who represent the top governance. So the activities of all these three are defined separately. When we look at the ROM 1, we would look at more of activities of the top governance of the board of directors or that level of governance. And some other elements would look at the functionings of the head of the organization, and some others would look at the departmental leaders. So their activities have actually been separated out in different standards in the ROM chapter.
Okay.
Yeah.
Thank you,
So,
sir.
another one.
Thank you very much. Now we are taking the next question from Miss Antonia P. Sir, her question is that what are the requirements for addressing safety officer, fire safety officer, patient safety officer? Whether undertaking for legal compliance will suffice the requirement while considering NABH as an accrediting body?
I'm sorry, are these two different questions?
No, sir, these are the
because
same.
One is related to the
yeah, these are
officer.
Interlinked.
Okay. So when we look at the safety officer, we would like to have a person in charge of safety who has some experience about patient safety as well as general safety. So it would not be a very good idea to have, say, the head of the security as the safety officer, because that individual would have no idea about anything related to the patient safety. And then if you have a pure clinician who has perhaps very little idea about general safety and security, would not also be a very ideal person to be a safety officer, because the safety officer is expected to look into the general safety as well as patient safety. So we'd like an individual who has experience from both these areas.
Okay, sir. Thank you very much. Sir, I'm taking question from Dr. Naveen Chug. Dr. Naveen. Dr. Naveen. Dr. Naveen, can you hear me? Sir, I think he cannot hear us. Never mind. We are taking another question, and it is from Dr. Rajiv Shore. Sir, what should be the frequency of HIRA in SCO?
There is no specified frequency for doing a HIRA, but then of course the more frequent you do it, the better it will be. You would identify more and more risks in your organization of different areas. What has now been specified is that HIRA, the hazard identification and risk analysis, should be done both in clinical areas as well as the non-clinical areas. That's what has been specified. The frequency of doing the same has not been specified.
Okay, thank you very much, sir. So the next question is from Ms. Anita Arora. Is there a standardized format that you can share to take undertaking from SCO that they are conversant with applicable laws and regulation and is adhering to them?
I guess all of us have been taking these indemnity letters, and we are all of us more or less following the same format. I'm not sure whether this has been formally launched by released by NABH, but then universally everybody is following the same indemnity format. I think that can still be used for taking as an undertaking.
Okay, sir. Sir, the next question is from Dr. Alka Singh. She is saying that should there be a separate area be designated by the organization to store hazardous material? Sir, this is the question. There should
Yes,
be
of course. We would like to have all the hazardous materials which are stored separately away from other materials, but it's not necessary that you have a separate room for storing all the hazardous materials. A separate area would do, with proper identification of the area, proper labeling, with proper MSDS put up in the particular area.
Okay, sir. Thank you very much. Sir, one interesting question comes from Dr. Subiraj John. He is saying that for an assessor who is primarily a clinician, could you suggest resources for gaining knowledge about facility and infrastructure issues?
I think that question applies to me as well, because I am a clinician myself, and with limited exposure to facility requirements. I think the best way is keep on reading. The more you read, I think you would get more information. We don't have any resources from NABH side as of now, and it would be difficult also to provide resources from NABH side, because the facility chapter talks about a large number of things. The best way for you probably would be to go ahead and read each and every, do a cross-referencing for each and every element which is there in the FMS chapter.
Okay, sir. Sir, one more question from Dr. Rajiv Shore. Sir, in ROM 1H, is it enough if SEO supports only one national program?
Now this is a new addition to the 4th edition standards, where we have not specified as to how many national programs should be supported by the SEO, but we would like at least some of the national programs are supported, considering the scope of the hospital. Now we would not expect that an ophthalmology institute would look into, say, the mental health act, mental health program. Within the scope of services of the organization, whichever programs that the hospital can support, we would like that. It is not in terms of number as to 1 or 2. If an organization likes to start with one program, it's welcome to do that, but at least some programs should be supported by the HCO.
Okay, sir. So the next question again from Miss Antonia P. If all the beds not having side rails, is it acceptable? And the second question, I think that this is the same question. While closing the NCs, the SEO send few beds with side rail. As per photo evidence, we accept. But during the final or reassessment, it is not completely closed. How to handle this type of smartness of SEOs?
Okay, can I have the first question, please, once again?
Sir, if all the beds not having the side rails, is it acceptable or not?
Okay, now certain groups of patients definitely require side rails. For example, pediatric patients, vulnerable patients of other types, they would definitely require side rails. But we would prefer that side rails are provided to all sorts of patients. Now, if the deficiency has been brought out during the assessment that the side rails were not there, and a few photographs of side rails having been put in place, have been provided by the HCO as smartness, as Antonia ma'am says. Now, there are various ways in which this can be checked. One thing is that during the next assessment which is carried out, this point can be reviewed by the next set of assessors. You can also ask for the number of side rails that have been installed, asking for the purchase orders for the different numbers of side rails that have been installed for the beds.
Okay. Thank you, sir. Thank you very much. So the last question I am taking from Dr. Naveen Chug. His question is that the frequency of water quality testing for STP should be as written in the authorization from the state PCB under the Water Act for the SCO. The problem arises when the SCO does not have this authorization under Water Act, but again authorization under Water Act is now mandated in BMW rules 2016. What should we do in this situation, in this kind of situations?
Naveen, I think this question should go back to you, being the legal expert, but I'll try to answer that one. The requirement of the potable water quality checking, as mentioned earlier, is to be done once a quarter. So, and if required, it should be done more frequently. Now, this, if required more frequently, would depend on any state notifications, any local notifications, on any other standards on water quality that the HQ is performing. So, I guess the Water Act authorization has not much to do with the water quality checking, because that is a license which has been obtained, and this is something which we are doing beyond the bar of raising the bar, going beyond the legal requirement of a license and checking water quality more frequently.
Okay, sir. Thank you very much. Sir, there are some more questions. Do you have, sir, time for addressing 2 or 3 more questions?
Yeah, I think we do have time.
Sir, the next question is from Ramesh Chandana. AAC mentioned that services not offered have to be displayed, whereas ROM 4D says that they can be conveyed verbally. Please explain.
Now we need to look into the AAC requirement of the display of services, where it says that those services which are directly linked to the services being provided, they should be displayed or not. They should be displayed saying that these are the services we are not providing. For example, if you look at a tertiary oncology center which is providing medical oncology, surgical oncology, not giving radiation oncology, then they must mention that they are not providing radiation oncology in that setup. But then if there are certain services which are not linked to the basic core services of the HCO, and these are not displayed as not being provided, that is fine. For example, if they are not providing, say, the hyperbaric oxygen therapy, now that is not closely linked to the services of the hospital. Now they need not display it particularly saying that HBOT is not being provided in the organization. This can be informed verbally to the patients.
Okay, sir.
So it's not actually a disconnect between the AC and the ROM. There is a connect between the two.
Sir, the next question is that who shall do the monitoring of effectiveness of the committees?
Now, if you look closely at the standards, you realize that the review of committees is mentioned at two different places. At one place it is mentioned that the quality improvement committee itself reviews the minutes of meeting of the different committees, and it is now also required as per the ROM chapter that the top governance, the top management also reviews the functioning of the different committees. They also get the reports of the safety committee and the quality improvement committee.
Okay, sir. The next question I am taking from Krishna Bhaskar Reddy. Dr. Krishna Bhaskar Reddy, you can hear me? Hello? Dr. Krishna? Sir, I think he cannot hear us. Okay, no problem. So here we are closing our question answer session. If anyone have any query, they can just give me a mail on helpdesk@nabh.co and we will address all the queries. Thank you very much for your patience, and thank you, Dr. Prashant, for your enlightening session. Thank you, sir.
Thank you, Mr. Prashant.
Okay, sir. Thank you very much.
Thank you.
Thank you, sir.